Welcome to the deep dive. Today, our mission is, well, it's a big one. We're trying to chart the line between just normal human variation and what gets classified as a genuine psychological abnormality.
Yeah, it's a really tricky area. We're diving into your sources today to unpack the standards, the models, and, the actual disorders that define psychological distress.
And it feels incredibly important because this isn't some abstract concept. The line between normal and abnormal, it seems like it's constantly shifting, doesn't it? Depends on context, culture.
Absolutely. Context and culture are everything here. And the scale of this issue, well, it's huge. It touches almost everyone's life in some way.
When you look at the numbers, you really see why we need some kind of framework, some standardization.
The statistics are pretty startling, actually. Your sources point out that nearly half, think about that, almost 46% of adult Americans will develop a diagnosable psychological disorder at some point.
46%. Wow.
Yeah. And right now, about 1 in 5 adults is dealing with what the sources call a serious psychological disorder. So this is absolutely central to understanding the human experience.
So our goal today is to understand how psychologists and researchers even begin to classify all this. We're going to unpack the criteria they use, the models behind their thinking, and we'll be referencing that big manual, the DSM-5.
That's right, the Diagnostic and Statistical Manual of Mental Disorders. It's the cornerstone for diagnosis in the U.S.
Okay, so if nearly half the population might meet diagnostic criteria eventually, defining abnormal must be incredibly complex. You can't just use one single definition, can you?
No, definitely not. Human behavior is just too varied for that. When you look at the 6 main criteria psychologists tend to rely on, you see right away that no single one works on its own. It's usually a combination, like a cluster of these signs.
Right, a pattern. Okay, let's walk through those 6. Where do they start? What's the first one?
Well, the first is probably the most straightforward. Unusualness. Is the behavior statistically rare?
Okay, rare. But that seems insufficient.
Exactly. It may be abnormal, but it's definitely not enough by itself. I mean, the sources give the example of being a genius that's highly unusual, right?
Right.
But we don't call it a disorder. So unusualness just flags something as different from the average.
Makes sense. So unusualness alone, isn't it? What's number 2?
Number 2 is social deviance. This one's trickier. It's about behavior that goes against the norms, the acceptable standards of a particular society at a particular time.
So this is where culture really starts to bite. Because those standards change, don't they?
Massively. And they vary hugely between cultures. What's perfectly normal, one place could be seen as deeply abnormal somewhere else. It's a really important point to keep in mind.
Okay, so unusualness, social deviance. What's third? This one seems more internal.
Right. The third is emotional distress. This is about the person's subjective feeling. But again, context is key. Feeling sad after a loss or anxious before a test, that's normal.
So when does it cross the line?
It's considered abnormal when the distress is, inappropriate for the situation or way out of proportion, or if it just goes on and on for far too long. Like crippling anxiety over a tiny issue, or grief that doesn't lessen at all for years and years. That suggests something's off in how the emotion's being regulated.
Got it. Okay, fourth criterion. This sounds more practical. Maladaptive behavior.
Yeah, maladaptive is about function. Is the behavior causing problems? Is it self-defeating? Does it lead to significant trouble in the person's health, their relationships, their job? If a behavior consistently makes life worse for the person or people around them, it's maladaptive. It's about whether it works in life.
That seems pretty clear-cut. What about the fifth one? Dangerousness. Surely if someone's violent, that's abnormal.
Often, yes. But again, context. Violent behavior is usually considered abnormal. However, think about soldiers in combat, or boxers in a ring, or even police officers in certain situations. Violence in those specific socially sanctioned contexts might not be labeled abnormal.
So the key is whether the violence is controlled, appropriate to the situation, or if it's like impulsive and out of nowhere.
Exactly. Is it rational and context-bound, or is it pervasive and uncontrolled? That's the clinical difference. It really shows the careful judgment involved.
Okay, and the final criterion, number 6, feels like a major break from reality.
It often is. This is faulty perception or interpretation of reality. This is where we get into things often linked with psychosis. And it's crucial here to distinguish between 2 key terms the sources highlight.
Okay.
First, hallucinations. These are faulty perceptions. Sensory experiences, seeing, hearing, feeling things that aren't actually there. Second, Delusions. These are faulty interpretations or beliefs, firmly held beliefs that are clearly false and resistant to any evidence, like believing you're being controlled by aliens.
So hallucinations are about senses, delusions are about beliefs. Got it. Both signal a pretty significant disconnect. ##B, the crucial role of cultural context.
Yes, a major disconnect. But even with these 6 criteria, unusualness, deviance, distress, maladaptive behavior, dangerousness, faulty perceptions, we have to constantly circle back to culture, especially with social deviance. These criteria aren't universal stone tablets.
Right, you have to filter them through the cultural lens. Ignoring that seems incredibly risky.
It's led to huge mistakes historically, pathologizing things that are perfectly normal, even valued in other cultures, or worse, using these labels to control marginalized groups. The very idea of self, or how you express distress, can be radically different across cultures.
Let's go back to that example you mentioned earlier, depression in Asian cultures versus Western cultures. How does that play out?
Well, the sources note that in many Asian cultures, where perhaps emotional restraint is valued more, people are more likely to somaticize depression, meaning they express it through physical symptoms.
Like headaches or fatigue.
Exactly. Headaches, stomach problems, overwhelming tiredness. They might report those things much more readily than saying, I feel sad or I feel hopeless, which might be more typical in, say, the US or Europe.
So a clinician trained only in the Western model might completely miss it. They're looking for reported sadness, but the patient is talking about physical pain.
Precisely. If your main tool is a questionnaire that asks about feelings in a very direct Western way, you could easily misdiagnose or just dismiss the person's suffering. It shows how our diagnostic tools themselves carry cultural assumptions.
That's a really important point. And thinking historically about how social deviance can be misused, the sources mentioned something called drapetomania. What on earth was that?
Drapetomania. That's a chilling example from American history around the 1850s. It was literally a proposed mental illness to explain why enslaved African Americans would try to escape.
Wait, running away from slavery was classified as a mental illness.
Yes. The act of wanting freedom was seen as so deviant, so irrational according to the societal norms of slavery supporters, that it was medicalized. It shows in the starkest way how social norms and power structures can warp the definition of abnormal into a tool of oppression. #CACs equators, evolving models of abnormal behavior.
That history really underscores the need to understand why we think certain behaviors are abnormal. We've talked about the criteria, the what. Now let's shift to the models, the how. How have explanations for abnormal behavior evolved?
Well, for a huge chunk of Western history, the dominant view wasn't scientific at all. It was supernatural. The idea of demonic possession. Strange behavior meant you were inhabited by an evil spirit.
And the treatment followed logically from that, I suppose?
Right. If it's demons, the treatment is exorcism, often involving prayers, rituals, but sometimes pretty brutal methods aimed at driving the spirit out. Not exactly therapeutic.
Thankfully, things changed with the Enlightenment. Science started to offer alternatives.
Yes. Around the 18th and 19th centuries, we see the rise of the medical model. This was a huge shift. It started viewing abnormal behavior patterns as mental illnesses, maybe like brain diseases, with a biological or physical cause. It moved things from the realm of sin or spirits into medicine.
Which was progress, definitely, but maybe too focused on just biology. It kind of missed the mind part, the psychological experience.
Exactly. The medical model was criticized for being too reductionist. So then came the psychological models. The first really big one was Freud's psychodynamic model. He argued the roots weren't in the brain, but in the mind specifically, in unconscious conflicts, often stemming from childhood. Abnormality was the result of the mind struggling with itself.
Then others reacted against Freud, focusing only on what you could actually see and measure.
That's the behavioral model. Behavior, it's like Skinner and Watson basically said, forget the unconscious, let's look at learning. They stressed how abnormal behaviors are learned through conditioning classical, operant, and through observation. And crucially, if it's learned, it can potentially be unlearned.
Okay, so we have biology, unconscious conflicts, learned behaviors. What else?
We also got the humanistic model from people like Maslow and Rogers. They focus on personal growth. They suggested abnormal behavior happens when something blocks our natural drive towards self-actualization. And then there's the cognitive model, focusing squarely on thoughts. It argues that irrational or distorted thinking patterns are the direct cause of emotional problems and maladaptive behavior. Change the thinking, change the feeling.
So many different angles. Biology, mind, learning, growth, thoughts. Where does modern thinking land? Does one model win out?
Not really. Contemporary understanding is much more about integration. We have the sociocultural model, which always emphasizes the broader social context, poverty, discrimination, cultural stress. But the dominant framework today, the one that tries to pull it all together, is the biopsychosocial model.
The biopsychosocial model. Okay, let's unpack that. It sounds like it just lists three things, but it's more integrated than that.
Oh, much more. It's a true synthesis. It insists that you can't understand a disorder by looking at just one factor. It's always about the complex dynamic interaction between biological factors like genetics, brain chemistry, psychological factors, thoughts, learned habits, coping skills, and social factors, culture, family, economic status. The cause isn't in one box, it's in the interplay between the boxes.
And a really key application of this integrative approach is the diathesis stress model. You said this applies to almost everything we'll discuss.
It's a hugely important framework, yes. The diathesis stress model helps explain why some people develop disorders and others don't, even when facing similar circumstances. It proposes two necessary ingredients. First, you need a diathesis, a predisposition of vulnerability. It could be genetic, like inheriting genes linked to depression, or it could be psychological, like having a very anxious temperament from childhood. It's an underlying vulnerability.
Okay, so you have the vulnerability, the diathesis. What's the second ingredient?
You need stress, exposure to significant negative life events or ongoing adversity. This acts as a trigger.
So someone could carry the genetic vulnerability for, say, schizophrenia their whole life, but if they live a relatively low-stress life, they might never actually develop the disorder.
That's the idea. The diathesis is like having, say, a predisposition for fragile bones. The stressor is like falling down the stairs. It's the combination, the underlying fragility, plus the specific event that leads to the break, or in this case, the onset of the disorder. It really highlights that complex interaction.
Okay, let's use that biopsychosocial lens, especially diathesis stress, as we move into specific categories of disorders, starting with the most common group, according to your sources, anxiety disorders.
Yes, anxiety-related disorders are incredibly prevalent. The core feature is an anxiety reaction that's either excessive for the situation or just inappropriate altogether. We all feel anxiety is protective, but this is when it becomes overwhelming, persistent, and really gets in the way of life.
The sources break down several types. Let's start with phobias. These are those intense, irrational fears of specific things, right?
Exactly. Irrational and excessive fear tied to a specific object or situation. The main subtypes are social anxiety disorder, intense fear of being judged or embarrassed in social situations. Specific phobia, fear of things like spiders, heights, needles, flying, and agoraphobia.
Agoraphobia is the one about open spaces.
Not exactly. It's more about fear of situations where escape might be difficult or help unavailable if panic strikes. So it often leads to avoiding public transport, crowds, or even leaving home. And interestingly, for specific phobias, some seem almost hardwired fears of snakes, spiders, heights. Evolutionarily speaking, it made sense to be wary of those things. We seem prepared to learn those fears more easily than, say, fear of cars.
That makes sense, a kind of evolutionary echo, but then there's panic disorder, which seems different. It's not tied to a specific thing, is it? It's more like pure fear itself erupting.
That's a good way to put it. Panic disorder involves recurrent, unexpected panic attacks. These are sudden episodes of intense terror that peak within minutes. The truly terrifying part for the person is the physical symptoms: heart pounding, sweating, trembling, feeling short of breath, chest pain, nausea. People often think they're having a heart attack or dying.
Which must make them terrified of having another attack.
Absolutely. That fear of the fear itself becomes a major part of the disorder. Then there's generalized anxiety disorder, or GDA. This is more of a constant free-floating anxiety.
You're floating.
Meaning it's not attached to any specific object or situation. People with GDA worry excessively about, well, pretty much everything: health, money, family, work, even when things are going relatively okay. It's this persistent, chronic sense of dread and unease that they can't shake.
That sounds exhausting. And finally, within this anxiety cluster, we have obsessive-compulsive disorder, OCD. Yeah. This involves thoughts and behaviors, right?
Yes, typically both. Obsessions are these recurrent, intrusive, unwanted thoughts, images, or urges that cause significant anxiety or distress. Common themes are contamination, doubt, order, or fears of harming someone.
And the compulsions are the response to those thoughts.
Exactly. Compulsions are repetitive behaviors like hand-washing, checking, counting, ordering, or mental acts, like praying or repeating words silently. The person feels driven to perform these compulsions in response to an obsession, usually to try and reduce the anxiety or prevent some dreaded event. but it becomes a vicious cycle.
Okay, so that's the what. Let's talk why. What's going on biologically with anxiety disorders?
There's definitely a biological component. Twin studies and adoption studies confirm a genetic predisposition. Anxiety disorders tend to run in families. Neurochemically, it's complex, but research often points to dysregulation in neurotransmitter systems, particularly those involving serotonin and GABA. And structurally, there's a lot of focus on the amygdala.
The brain's fear center.
Kind of, yeah. It processes emotional significance, especially fear. The idea is that in anxiety disorders, the amygdala might be hyperreactive, essentially sending out false alarms or overreacting to potential threats. It's like the brain's threat detection system is stuck on high alert.
And psychologically, how do learning theories explain these, especially phobias?
Learning plays a huge role. A specific phobia might start through classical conditioning. For example, a child gets bitten by a dog, unconditioned stimulus causing fear, and then develops a fear of all dogs. Conditioned stimulus now causes fear. Simple association.
But why does it persist? Why don't people just learn that most dogs are friendly?
Because of operant conditioning, specifically negative reinforcement. When the person avoids dogs, their anxiety immediately goes down. That feeling of relief reinforces the avoidance behavior, so they keep avoiding dogs, never get the chance to unlearn the fear, and the phobia sticks.
The avoidance is rewarded by reduced anxiety. And that same negative reinforcement pattern drives the compulsions in OCD too, doesn't it?
Precisely. The obsessive thought creates intense anxiety. Performing the compulsion, washing hands, checking the lock, temporarily reduces that anxiety. That relief negatively reinforces the compulsion, making the person feel they have to do it next time the thought pops up. It's a powerful cycle maintaining the disorder.
Okay, let's shift gears to a different, maybe more unusual category. Dissociative disorders. These involve disruptions in consciousness, memory, identity, a sort of fragmentation of the self.
That's a good way to describe it. Dissociative disorders involve a disruption or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. Parts of the self seem to split off or become inaccessible.
The most common one, according to the sources, is dissociative amnesia. What does that look like?
This involves an inability to recall important personal information, usually related to trauma or stressful events, that can't be explained by ordinary forgetfulness or a medical condition like a head injury. It's psychologically induced memory loss. It's usually localized, forgetting a specific period rather than generalized, where someone forgets their entire identity, which is actually quite rare despite what you see in movies.
And then there's the really controversial one, dissociative identity disorder, or DID-D. This used to be called multiple personality disorder.
That's right. DID-D is characterized by the presence of two or more distinct personality states or identities, often called alters, that recurrently take control of the individual's behavior. There are often significant gaps in memory for everyday events, personal information, or traumatic experiences that are too extensive to be explained by ordinary forgetting.
The sources seem to strongly link D to severe childhood trauma.
Yes. The vast majority of case histories report histories of severe, chronic, often unspeakable physical or sexual abuse, typically starting in early childhood. The leading psychological theory is that developing alternate identities is a kind of extreme coping mechanism. It's a way for the child's mind to compartmentalize the overwhelming trauma, to wall off the unbearable experiences into separate parts of the self as a means of survival.
But you mentioned it's controversial. Why are some experts skeptical about DD?
Well, the skepticism comes from a few places. Some point out the diagnoses were extremely rare until the 1970s, and then seemed to skyrocket after popular books and movies like Sybil came out, suggesting a possible sociocultural influence or even fad element. Others worry about suggestibility, that maybe therapists, sometimes unintentionally through certain questioning techniques or hypnosis, might actually encourage or shape the presentation of alters in vulnerable individuals. There's also debate about whether it's sometimes a form of elaborate role-playing.
So it's this complex debate between seeing it as a genuine, albeit rare, trauma response versus potentially something influenced by culture or even therapy itself.
Exactly. It's a very contentious area within psychiatry and psychology. The reality is likely complex, involving genuine trauma responses in some cases, and perhaps other factors contributing in others.
Now let's move to another fascinating intersection of mind and body. Somatic symptom and related disorders. Here, the primary issue looks physical, but the cause isn't found in the body.
Precisely. These disorders involve prominent physical symptoms associated with significant distress or impairment, but where medical examination finds no explanatory physical condition, or if there is a condition, the person's reaction is way out of proportion, the physical suffering is real to the person, but its origins are believed to be psychological.
A classic example from the sources is conversion disorder. What happens there?
Conversion disorder involves symptoms affecting voluntary motor or sensory function, things like sudden paralysis, blindness, deafness, seizures, or loss of feeling in a limb, but with no underlying neurological or medical cause. The physical pathways are intact, but they're not functioning correctly due to psychological factors.
And there's that really strange detail about la belle indifference.
Yes, the beautiful indifference. Some, though not all, people with conversion disorder show a surprising lack of concern about their dramatic symptoms. Someone might become suddenly blind but seem remarkably calm about it. This apparent indifference can be a clue that the symptom might have psychological roots, as someone with an organic condition would usually be quite distressed.
Okay, and then there's the condition people used to call hypochondriasis. The terminology changed?
Right. Hypochondriasis isn't really a formal diagnosis anymore in the DSM-5. The core issue, being preoccupied with fears of having a serious illness based on misinterpreting minor bodily symptoms, is now typically diagnosed as either somatic symptom disorder, if there are significant physical symptoms causing distress, or illness anxiety disorder, if the main issue is the anxiety about illness with few or no actual symptoms. The focus shifted slightly.
So, if there's no physical cause, what is causing these very real physical symptoms or anxieties? What do the models suggest?
Well, going back to Freud, he saw conversion symptoms as the physical expression of repressed unconscious conflicts. He also talked about secondary gain, the idea that the symptom, while distressing, might also provide some benefit, like getting attention, sympathy, or being excused from difficult responsibilities. It's not conscious manipulation, but an unconscious process.
So the symptom solves a psychological problem, in a way.
That was his view. Learning theorists take a related perspective, suggesting the symptoms might be reinforced because they allow the person to avoid stressful situations or receive care. Cognitive theorists focus more on thinking patterns, suggesting people with these conditions might have attentional biases, focusing excessively on bodily sensations and catastrophic thinking, interpreting harmless sensations as signs of disaster. It's likely a mix of factors.
All right, let's turn now to mood disorders. These are about disturbances in emotional experience that are severe and persistent enough to cause real impairment.
Yes, mood disorders involve significant shifts in emotional state, going far beyond the normal ups and downs of life. The most common is major depressive disorder, or simply major depression.
What defines major depression? It's more than just feeling sad, right?
Oh, much more. It's characterized by a period of at least 2 weeks of either depressed mood or, crucially, a loss of interest or pleasure in almost all activities, what we call anhedonia. Plus, you typically see changes in appetite or weight, sleep problems, too much or too little, fatigue, feelings of worthlessness or excessive guilt, difficulty concentrating, and sometimes recurrent thoughts of death or suicide.
The prevalent statistic you mentioned earlier was shocking: 1 in 5 U.S. adults experiencing it sometime in their life. And the gender difference.
Yes, consistently, women are diagnosed with major depression about twice as often as men. The reasons are complex and debated, but likely involve an interplay of biological factors, like hormonal influences, psychological factors, women may ruminate on negative feelings more, and sociocultural factors. Women often face greater stress burdens, discrimination, and different societal expectations.
Okay, so depression is that persistent low. What about the other major mood disorder mentioned, the one with the highs and lows?
That's bipolar disorder. This involves shifts in mood, energy, activity levels, and concentration, swinging between periods of depression, similar to major depression, and periods of abnormally elevated, expansive, or irritable mood known as mania, or a milder form called hypomania.
Mania, what does that look like?
During a manic episode, a person might feel euphoric, full of energy, need very little sleep, talk rapidly, have racing thoughts, and show poor judgment, maybe going on spending sprees, engaging in risky behaviors, or having inflated self-esteem. It can be highly disruptive, sometimes requiring hospitalization. Bipolar disorder affects about 1% of the adult population.
So what drives these extreme mood states? Psychologically, what's going on?
From a psychological perspective, stress is a major trigger for both depressive and manic episodes. Negative thinking patterns are huge in depression. People often develop a depressive attributional style.
Meaning how they explain events.
Exactly. They tend to attribute negative events to causes that are internal, it's my fault, stable, it's always going to be this way, and global. It ruins everything. This ties into the learned helplessness model.
Learned helplessness, that's the idea that you just give up.
Pretty much. It suggests depression can result when people learn from experience that they have no control over negative events or reinforcements in their lives. If you believe nothing you do matters, you stop trying, leading to that passivity and hopelessness seen in depression. Changes in reinforcement levels, like losing sources of pleasure or reward, also play a role.
And biologically, what's the evidence there for mood disorders?
The biological evidence is very strong. There's a significant genetic component. These disorders definitely run in families. Neurochemically, much of the focus has been on neurotransmitters, especially serotonin, norepinephrine, and dopamine. The older chemical imbalance idea is probably too simplistic, but dysregulation in these systems is clearly involved. Low serotonin activity is strongly linked to depression, while fluctuations in various neurotransmitters seem involved in the shifts seen in bipolar disorder. #B. The critical topic of suicide.
This leads us to a very difficult but critical topic, suicide. The sources are clear that it's almost always linked to a diagnosable psychological disorder, particularly mood disorders, and driven by profound hopelessness.
Yes, suicide is a major public health concern, and understanding the links to mental health is vital for prevention. It's tragically the second leading cause of death for young people ages 10 to 34 in the U.S. That feeling of inescapable pain and hopelessness is often the final common pathway.
Beyond the link to disorders like depression or bipolar, do the statistics point to other risk factors we should be aware of?
Yes, there are definite demographic patterns. Age is one, while it's high in young people, rates are also very high among middle-aged adults and particularly older adults, especially men over 65. Gender shows that stark difference. Women attempt suicide more often, but men complete suicide much more frequently, often using more lethal methods. And race ethnicity varies too, with Native American and Alaska Native populations having tragically high rates, followed by white Americans, with lower rates generally among African American and Hispanic American populations.
Is there a biological angle to the act of suicide itself, separate from the underlying disorder? Something about impulsivity?
Research suggests there might be. Specifically, studies have found links between suicidal behavior and dysfunction in the serotonin system. Low levels of serotonin metabolites have been found in people who've died by suicide. One theory is that impaired serotonin function might lead to a disinhibition effect.
Disinhibition, meaning?
Meaning it weakens the brain's normal impulse control mechanisms. It removes the usual psychological brakes that stop people from acting on dangerous or self-destructive urges. So, in a moment of intense pain and hopelessness, impaired serotonin function might make it harder to resist the suicidal impulse. Genetic factors regulating serotonin also seem to play a role.
Given how serious this is and the emphasis on prevention, what are the key action steps if you encounter someone who seems suicidal? What do the sources say we should do?
The key is to act decisively and compassionately. First, take any threat or mention of suicide seriously. Don't dismiss it. Try to gently assess the immediate risk. Do they have a plan? Access to means. Second, listen without judgment. Express understanding and concern. Third, focus on alternatives. Remind them that intense pain is often temporary and help is available. Don't argue, but don't agree that suicide is a solution. Fourth, and absolutely critical, get professional help immediately.
Don't just suggest it, actually help them get it.
Yes. Don't leave them alone if you believe the risk is high. Try to get their agreement to seek help and then actively help them connect. Go with them to an emergency room. Call a crisis hotline together. Contact the mental health professional. That active support and connection can be life-saving.
Okay, let's move to another severe disorder, one often associated with a profound break from reality: schizophrenia. It affects less than 1% of the population, but its impact is immense.
Schizophrenia is indeed a severe chronic disorder. It's characterized by major disturbances across multiple domains: thinking, perception, like hallucinations, emotions, often flattened or inappropriate, and behavior. It fundamentally alters a person's experience of reality.
What are the core symptoms we should understand? It sounds like a complex cluster.
It is. Key features often include hallucinations, most commonly hearing voices, delusions, fixed false beliefs, often paranoid or bizarre, disorganized thinking, manifesting as incoherent speech, sometimes called thought disorder or word salad, and grossly disorganized or abnormal motor behavior.
I've heard symptoms described as positive and negative. What does that mean?
That's an important distinction. Positive symptoms are things that are added to normal experience excesses or distortions. Hallucinations and delusions are classic positive symptoms. Negative symptoms involve a loss or deficit in normal functions. Things like reduced emotional expression, flat affect, poverty of speech, alogia, lack of motivation, avolition, inability to experience pleasure, anhedonia, and social withdrawal.
Do negative symptoms suggest a worse outlook?
Often, yes. Negative symptoms can be more persistent and less responsive to medication, often contributing significantly to long-term functional impairment. Sometimes you also see catatonic behavior ranging from complete lack of movement and responsiveness, stupor, to maintaining rigid or bizarre postures, sometimes with that waxy flexibility where someone else can move their limbs into positions they'll then hold.
This sounds like it must have a strong biological basis. What does the research point to?
The biological evidence is overwhelming. Genetics play a major role. Having a close relative with schizophrenia significantly increases risk. Biochemically, the dopamine hypothesis has been central for decades.
The idea that it's about too much dopamine?
It's more nuanced now. The current thinking is more about imbalances in dopamine pathways. Excessive dopamine activity in certain brain regions, like the mesolimbic pathway, seems linked to the positive symptoms. But deficient dopamine activity in other regions, like the prefrontal cortex, the mesocortical pathway, might contribute to the negative symptoms and cognitive deficits. Other neurotransmitters like glutamate are also implicated.
And structurally, do brains look different?
Often, yes. Brain imaging studies frequently show structural differences, most commonly in large ventricles, the fluid-filled spaces in the brain. This enlargement suggests a loss or reduction of surrounding brain tissue. Areas often affected include the prefrontal cortex, involved in executive functions, and parts of the limbic system, involved in emotion, potentially disrupting communication between these crucial regions.
So strong biological roots, but does environment still play a role? Back to diathesis stress.
Absolutely. Schizophrenia is a prime example of the diathesis stress model. You have the biological vulnerability, the genetic predisposition, maybe the brain structural differences, the diathesis. But the disorder often seems to be triggered or exacerbated by environmental stressors, things like prenatal complications, early childhood adversity, heavy substance use, especially cannabis in adolescence, or even the stress of urban living or migration. It's that interaction again. Biology loads the gun, environment might pull the trigger.
Okay, our last major category is personality disorders. How are these different from, say, mood disorders or anxiety disorders, which seem more episodic?
Personality disorders are different because they're defined by enduring, inflexible patterns of inner experience and behavior that deviate markedly from the expectations of the individual's culture. These patterns are pervasive across a broad range of personal and social situations. They're stable over time, often traceable back to adolescence or early adulthood, and they lead to significant distress or impairment in functioning. It's less about episodes and more about the fundamental way the person relates to the world and themselves. #A. Antisocial personality disorder, APD.
Let's talk about one that gets a lot of attention, often in a criminal context. Antisocial personality disorder, APD.
Right. APD is characterized by a pervasive pattern of disregard for and violation of the rights of others. This can manifest as deceitfulness, impulsivity, irritability, and aggressiveness, reckless disregard for safety, consistent irresponsibility, and crucially, a lack of remorse after hurting or mistreating others. They often have a callous, cynical attitude.
But the sources mentioned a paradox. Not everyone with APD is a criminal, right? Some are quite successful.
That's a key point. While APD is overrepresented in prison populations, most people who meet the criteria are not incarcerated. Many function in society, sometimes very effectively, using traits like superficial charm, manipulativeness, and intelligence to get ahead. They might be seen as ruthless business people, con artists, or just individuals who consistently exploit others without guilt. The terms psychopath or sociopath are often used informally to describe this pattern, particularly the more severe, calculating types.
It's hard to grasp how someone can function like that without empathy or conscience. What are the roots of APD?
Like most things, it seems to be a mix of nature and nurture. There's a definite genetic influence. Biologically, research often points to abnormalities in brain structure and function, particularly in the prefrontal cortex, the area responsible for planning, decision-making, impulse control, and understanding consequences. There might also be differences in autonomic nervous system reactivity, leading to lower levels of fear and anxiety, which might make them less deterred by punishment.
And the environmental side. Childhood experiences.
Environment plays a critical role too. Many individuals with APD have histories of unstable or chaotic childhoods, parental neglect, abuse, inconsistent or harsh discipline, exposure to violence. These early experiences might interfere with the development of empathy, attachment, and the internalization of social norms and moral values. Hashtag B. Borderline personality disorder, BPD.
Okay, let's discuss another personality disorder, one known for intense instability, borderline personality disorder, BPD.
BPD is characterized by a pervasive pattern of instability in interpersonal relationships, self-image, and emotions, along with marked impulsivity. People with BPD often experience intense fears of abandonment, have chaotic relationships that swing rapidly between idealization, you're perfect, and devaluation, you're terrible. Struggle with a stable sense of identity, engage in impulsive behaviors like substance abuse, reckless spending, self-harm, and have difficulty controlling their anger. Their emotional states can shift dramatically and quickly. It affects about 1.4% of adults.
The sources had a note about gender and diagnosis here.
Yes, that's important. BPD is diagnosed much more frequently in women than in men in clinical settings. However, research hasn't definitively shown that women are actually more likely to have the underlying disorder. This raises concerns about potential gender bias in diagnoses. Perhaps clinicians are quicker to apply the BPD label to women exhibiting emotional instability or relationship difficulties than to men with similar presentations who might get different diagnoses.
Interesting. So what causes BPD? Is it also that mix of biology and environment?
Very much so. It's considered a classic example of the biopsychosocial model in action. Environmentally, there's a very strong link to early adverse experiences, particularly childhood trauma like physical or sexual abuse, neglect, or highly invalidating environments where their emotional experiences were dismissed or punished.
And biologically?
Biologically, there seems to be a genetic vulnerability. Research also points to potential dysregulation in brain circuits involved in emotion regulation, particularly involving the amygdala, again, involved in emotional intensity, and the prefrontal cortex, involved in controlling impulses and emotions. The theory is often that individuals with a biological predisposition for emotional sensitivity and impulsivity, when raised in chronically invalidating or traumatic environments, are at high risk for developing BPD. Hashtag tag 6. Conclusion and final thought.
Wow. We've covered a vast territory today. From trying to define abnormal with those 6 criteria through the historical models and then diving into anxiety, dissociation, mood disorders, psychosis, and finally these ingrained personality patterns.
That's a lot. And the consistent theme, really running through almost all of it, is that biopsychosocial perspective. It's rarely just genes or just trauma or just thoughts. It's the intricate dance between biology, individual psychology, and the social world we live in. From the diathesis stress model and schizophrenia to the way learning reinforces anxiety, it's all connected.
And the tool used to try and map all this complexity, to give clinicians a common language, is that manual we mentioned at the start, the DSM-5.
Exactly, the Diagnostic and Statistical Manual of Mental Disorders. For all its debates and revisions, it provides the standardized criteria that allow professionals to communicate, conduct research, and hopefully choose effective treatments based on identifying these distinct patterns of behavior and experience. It brings some order to a very complex field.
And this feels like a crucial, but the sources also emphasize that the DSM isn't perfect. There are ongoing debates, questions about it.
That's right. Even with the DSM-5, significant questions remain about the reliability, how consistently different clinicians reach the same diagnosis, using the criteria and the validity whether the diagnostic categories actually represent distinct, real underlying conditions for some disorders. The boundaries can still be fuzzy.
So here's the final thought we want to leave you with. Our understanding of the mind, our very definition of what's normal and abnormal, it's not set in stone. It's constantly evolving through scientific discovery, cultural shifts, even social debate.
So if even our current gold standard, the DSM-5, is still grappling with fundamental questions about reliability and validity for some conditions, consider this. What happens next? How might future research or changing societal views reshape these categories? What might the next version of the DSM look like, and how profoundly could that shift our collective understanding of normal itself?
Something to think about. We leave you with that thought to explore.